statement, you also in favor of generic medicine.
My question is that generally in India, only few people only know that generic medicine. Why we do not promote? I'm not saying that we have to do some innovative research, sir. Because already generic medicines are existing.
Yes.
I think I'm asking to the Dr. Reddy to answer.
Doctor doesn't promote generic practice.
Oh, simple answer.
It doesn't get much cut off. It doesn't get the commission out of it. All the big pharmaceutical companies like GSK about the price is too much, and our generic drug is 5 or 10 paise. And the innovative drug is 2,000 rupees or 20 rupees, 30 rupees. Even if you say even the multivitamin, the 10 rupees will get straight, but the bigger companies it's 250 rupees, 500 rupees, because they get more commission. Obviously, the company doctor.
We are more into biosimilars. Biosimilars and generic medicine for a simple reason: affordability and accessibility. That is a simple reason, because most of the innovative drugs, they go through the patents. So since you have the patent rights, you cannot afford to buy such highly priced medicine, especially in a country like India where the poverty line is most of the people are below the poverty line. So they cannot afford innovative drugs. So we always go for biosimilars, not for the biological drugs. Now biological drugs are also come out. We don't go for the chemical entities. We don't go for the innovative drugs for the simple reason of the cost.
Now, sir, yes.
Yeah. So, doctors aside, I think the generics don't necessarily go through the entire process of the clinical trials, rigor of clinical trials, because of which the efficacy of that generic is not necessarily tested through that rigor. Therefore, if you want to rely on a clinical outcome, you would probably tend to believe something that has gone through the entire cycle of the clinical trials, right from safety all the way to outcome. So I think that is also an important aspect of why people should prefer a branded or non-generic NCE molecule.
Okay, the second question is that as the concept of the mission of the conference is, where do we stand on digital health initiative in India? Since the last 4 years, I think the talks are keep on moving on. Where do we stand?
You repeat the question, please. I'm not clear.
Especially, I am talking in generally. If you see last 4 years, Honorable Prime Ministers keep on started the digital India, digital health, the digital movement. Now my question is that where do we stand? See, I'm a chemistry professor. I will go practical approach.
I understand that. You see, in India, unfortunately, the leaders, the well-wishers, they try to promote research, they try to promote new technologies, innovations, or whatever. In political sense, what is happening, whatever one party is ruining the country, the opposition party will say, what 1 plus 1 is going to do, the party says, ruling party. The opposition party will say, no, it is not 1 plus 1 is going to do, it is 1 plus 1 is equal to 2. You got that?
I got it, sir. There will be group of people work, 1 plus 1 also can become 11.
That is there.
We also. Okay, then now I come to the final one.
You understood the idea now?
Yes.
It's not that we are not doing.
No, sir, I didn't say that we are not doing. I simply asked, where do we stand? That is only the...
No, we do stand comfortably at par with any other country. There is no doubt about it. Okay? Theoretically, conceptually, philosophically, we are no less than any foreigner. But as far as the implementation is concerned, we can't even take one step. And that's a fact.
This is my last question, and now I am answering to that question because you raised a question to the Dr. Rajan regarding the quality and education of the Indian system. As a professor, I myself also do evaluate and educate, prepare many of the courses. As for the current scenario of the Indian education system is more worse than anywhere in the world. Number one, I myself strongly against the current systems. See, nowadays the teachers or even any of the organization, they never analyze the scheme on the basis of the student choice. Because it's not a question about how much syllabus we covered, it's a question is that whatever we covered, whether the student can able to understand or not. I am in the view that as a practical approach, if there is a 3 credit courses, then it should be fixed for only 36 hours. It should not go beyond that one. So nowadays what is happening is that due to the privatization or so many of competition, there is a lot of burden to the student rather than teachers are taking their own risk. Simply given assignment or teaching karo, this karo, no. See, still I do believe that even though technology is advanced, still I believe that our old teaching methodology. Teach the student in the board, whichever the important is, go for the PowerPoint. So what I want to say is that the teaching methodology should be improved. Second thing is that the faculty should be trained very well. It is a perception that in India, 90% of the faculty are intelligent. It is not at all true. Even 80% of the existing faculty members, they never update what is happening on the latest trend. So in that competition, the students are in a trouble. So according to my opinion, the methodology of the syllabus should be minimized. Teaching should go a little bit more there, and frequently faculty development programs should be conducted for the faculty, and the teaching methodology also should go alignment with the student. I also don't believe that I am intelligent. Suppose other student not intelligent, you should not blame the student, because students are coming from the different backgrounds. Due to certain reason, they cannot be able to study. It is not their mistake. We are the society. Once I am the head of the organization, it is my responsibility to train all the students, not only to train the brilliant student. So the concept of the India, even our organization, they are discriminating the students. So that methodology has to be changed. Nothing needs to be difficult, but slightly we need to change the methodology. We need to go as per the student choices rather than the faculty choice. If we move this one, the work system will go even. Only two simple things. Curriculum has to be modified. Second thing is that conduct of examination. The question paper also has to be modified. It is not like that you give n number of choices. When you decide the 3 hours examination, why choices required? Set for only 100 marks means 10 questions. Don't go choices. Make the simple and effective. In that way, it will develop. Thank you.
Your points are well taken. This could be discussed in a different forum.
Yes.
Thank you, sir. Returning back to the forum, actually. Dr. Pumale, yesterday you had discussed the predisposition to the genetic diseases. And so what do you think is the Indian perspective on that? Because if we are predisposed and companies like genomic companies are offering tests for that, and are people willing to take those tests?
I think as the medical fraternity in India, or maybe in a global perspective, merging clinical aspects into the, genetic perspective into the clinical field itself is now emerging. Probably in the Western countries, the clinicians also are aware of genetics. Yes, they do an in-depth analysis. They do their genetic analysis before they treat a patient. Most I'm correct. Because they hold a PhD in genetics. A medical practitioner has a degree in holds a PhD in genetics.
Is that the reason we don't have 23andMe in India?
So let me take this. So the thing is, before I go into the detailed this thing of it, the very fact of accepting genetics or the father of genetics as all his findings and all that itself took a long time, probably 40 years. Mendel had a very, once he had come out with all his findings, he just worked on a simple thing on a pea plant. And then he had written a wonderful thing about all his findings. But people never cared, because when people come with something new or innovation, nobody wants to put it to practice until somebody else, digs out and then they come. And that was given posthumously. Probably it took 40 long years for him to have a recognition. So you can see how genetics was, And then I'm coming to the next one. Once it was having got a recognition, that's a classical genetic got a recognition. Then followed by all this, Darwin's theory and the other, the Watson and Crick, and then the modern genetics and all that. It had immediate effect in the Western population. People started understanding, and then started working on that and treating the people or patients based on that, the amino synthesis and all that stuff. It was everything was the analysis was done at a primitive stage itself when the child was, the fetus was in the in the early stages of the pregnancy itself. So it was mandatory that they were getting it tested so that the burden is not very high on the it should not be an economic burden for the society as well as the parents. So that's the thing. Like it was, the mindset was very clear, and then there was a lot of the awareness was there. So that is one part of the story. But when coming to India, in spite of we having a very strong family background, a very good family history, and the pedigree analysis, everything, we are not still accepting that genetics plays a vital role. It's now emerging. Yes, after having all.
So you are saying consumer genetics is still yet to come in?
Yeah, it is happening, but then how people are once they get when they go for a prenatal diagnosis and how many of them go for abortions? It's still it's still a bit ethical thing, which is they're ready to accept whatever comes their way, except for gender bias. That's where they do sex determination is only where they go for genetic analysis. But when it comes to disease, it's still in the primitive stage. When you say cancer, the BRCA1, BRCA2, and then it comes to the papillomavirus, and when it comes to many genetic tests for the single gene mutations and other genetic diseases.
Single panel and multi-panels, single gene panel, multi-panel.
Yeah. So those things are still, it's still, only in the educated societies, not in the rural population as such. Maybe it's still not penetrated into those areas. But yes, some of the thalassemias, the sickle cells, probably the thalassemia, there is some. People are still taking into consideration. And then when you see the down south, there's a lot of consanguineous marriages taking place. So the consanguineous marriages, how it leads to a lot of hereditary disease. So there again, people they are aware of it, but how far they are trying to inculcate that and then try to understand it and then try to eradicate it at the early stages so that it doesn't become a burden for the society. That's still a question.
Dr. Madhur, is this prescription driven mostly B2C, or because we have got the NIPT now, NIPT test that is coming up very fast in India, and other tests, multi-gene panels for cancer, other cardiovascular diseases as well. Now, is this prescription driven by doctors, or how do corporates actually go about getting this business?
So by mandate, it has to come from a clinician. Because the data interpretation that will be provided by the service provider or the diagnostic company should go to the clinician with specific actionability that is interpreted out of what comes out of the test. So clinical interpretation plays a major role in findings of a multi-gene test or even a single gene test. In a single gene hereditary test, it should be a mandate that a well-qualified, experienced genetic counselor counsels the patient and the doctor both. But lack of regulations in India do allow certain allowances for a lot of businesses to sort of throw caution to wind sometimes and not be as thorough as it's required for these tests to be airtight. So the major challenge of a genetic test is to interpret it. Even hereditary tests, single gene hereditary tests that are done, inborn errors of metabolism that are ascribed to specific genes, there is a genetic component, major genetic component that has to do with heredity, family history, and there's a lot of interpretation that goes into it.
Right.
And the lack of regulations allow a lot of compromised reporting, which is not in line with good health for the patient. And then the somatic part, there is a lot of variants that you see, you don't know the pathogenicity of those variants in the context of treatment.
And how significant is that variant?
Exactly. So again, that needs to be interpreted by a qualified MD PhD person who understands both aspects of that variant that we find. And that structure is majorly lacking in our society. Part of it has to do with regulations, and part of it has to do with lack of awareness in itself. But I think it's an evolving area, rapidly evolving area, and we should look to develop those expertise here and create that opportunity within our society.
Right. So that brings to the informatics. I want to take up the informatics part now. We have discussed a little about genome informatics and genome analytics. Back on the adoption of IT in terms of big data analytics and IoT kind of technologies, where do we stand actually at the moment?
I think there are a number of companies in the Silicon Valley which have tried to analyze a large set of genome data and trying to understand the makeup of certain diseases and things like that. There's one Stanford startup and very popular one, but well busted out actually. Genome analytics, while it is going on, I mean, that is the big area.
You mean BINA technologies? You might be recognizing the BINA technology.
Yeah.
It was acquired by Roche.
Yeah, Roche, exactly. And that is actually the big data. If you really look at it, I don't even consider the financial data, social media. When it comes to genome, it beats everything actually.
Correct.
And while that is going on, I think it's, in my opinion, it's there. It's still in the infant stages. Still, we need a lot of compute and memory and everything has to get cheaper for it to still see the end of the life. But on the IoT side, there's a lot of promise happening. An example is, I was working with Xerox PARC on a project actually, which was trying to have a small nano device, this was about 8 years back, which could supply the insulin based on the blood sugar at some point in time. So there's a controlled mechanism of releasing the insulin, it's an implantable device, and then it was still in the works actually, but it's not come out if I'm right. Things like that, and something in vitro fertilization. They've gone in that area, they've gone a little bit deeper, and they're trying to get devices available for women to make sure